disease, and they are still in the pediatric age group. The one-third story is that, you know, lifestyle intervention is the mainstay of treatment, and we have to implement it, but it might not be enough because patient might progress with lifestyle intervention. So prevention of the occurrence of the disease is the most powerful intervention we can apply. And I have to stress that MASLD, as Dr. Roberts said, is right now the leading cause for liver transplantation in adults. So it's the most common liver disease in the adult, and it's going to be a problem for our population. And I'm not going to spend a lot of time on this because Dr. Robert, did a great job outlining this. But this is again have changed the way we manage patients with steatotic liver disease, because now the diagnosis depends on the presence of steatosis by ultrasound. And once you identify a patient with steatosis, then you have to ask the question, do they really have cardiometabolic criteria? And I have here the pediatric criteria. They are pretty much the same as the adult, but we in pediatric have a kind of different cutoff based on age. And those cardiometabolic criteria are related to hyperlipidemia or dyslipidemia, hypertension, risk of diabetes, and of course body weight and waist circumference. So again, when we have a patient with steatotic liver disease, these patients, most likely cause going to be metabolic dysfunction, and this metabolic dysfunction might be just steatosis or might progress to steatohepatitis. But it's very important in children to rule out other etiology, because those are growing children. The incidence of genetic disease might be higher because genetic conditions do manifest earlier in life. So it's very important to look at those monogenic disease. But most importantly, it's very important to look at drug-induced liver injury or drug that might present with steatosis. And those are mainly prednisone. So it's if you are a pediatrician, if a patient doesn't need prednisone, maybe thinking about another steroid-sparing agent to treat them. Psychotropic medication like the Zoloft or the SSRI, sometimes they are used without clear indication, but those can induce steatosis. And chemotherapeutic agents and some antiarrhythmic drugs can cause steatosis. The monogenic disease list is long. Among those are conditions that we used to call lean NASH in the old nomenclature, but these are important to screen for, especially in young kids, to make sure that they don't have, for example, a genetic disease like Wilson's disease or alpha-1 antitrypsin deficiency, or hereditary hemochromatosis, among other genetic conditions. And there are also miscellaneous conditions. Those are conditions that can coexist with MASLD, so it's important to screen for them and treat them if you identify them. And these might be the viral hepatitis, hepatitis C and hepatitis B, HIV, autoimmune hepatitis, celiac disease. And again, steatosis might happen because of malnutrition. It's not always because of excess nutrition. And here I'm having also, stressing the message, please don't, overlook other causes of liver disease in this patient population and try to do a thorough workup for them. And the MET-ALD that Dr. Robert kind of outlined and the alcoholic liver disease are uncommon in pediatrics, but the recommendation for our society is to screen for alcohol consumption in children 12 years older. We assume that they're not using, but it might not be the case. So it's important to ask and counsel them and try to avoid this behavior early in life. The cryptogenic causes of steatosis is kind of rare in the pediatric population as well. That's why I have those grayed out. So, how we screen patients for MASLD? Our society recommendation is to screen obese or overweight pediatric patients between the age of 9 and 11. And now the nomenclature have changed, and the way we screen patients different, but it's not realistic to do ultrasound on population basis. So we still use the ALT, the liver enzymes, to screen patients. I have to remind people that the cutoff of normal ALT in the pediatric population is set a little bit higher than it should, so you might miss some of the patients. So for the normal ALT for boys is 26, and the normal ALT for girls is 22, but some of the children's hospitals have a value around 50, considered normal. And sometimes you might miss patient with MASLD if you use the cutoff of 50, because they might have MASLD with an ALT of 50. But most of our patients who have, progressive conditions, they will have liver enzymes at the 80 and above. So if you have someone with elevated liver enzyme and you don't know the reason, and these elevation are persistent, those are the patients that need to be referred to a pediatric gastroenterologist or hepatologist. So, again, bringing the message back, the importance of preventive strategy, and these prevention need to happen early in life and need to happen at the individual level and at also the community and the public health level. And at the individual level, as we said, the root of the problem is start early on during gestation. So it's important for pregnant mother to watch their diet, be physically active if their condition allows, avoid obesity, avoid diabetes. And in infant, breastfeeding is very important, especially during the first 2 years of life. Early introduction of complementary food before the age of 6 months increase the incidence of obesity. So, and also it depends what are you introducing early on. You don't want to introduce high carbohydrate, high fat for growing infants. So being aware about this issue goes a long way. And also using antibiotic and acid blocker have been linked to alteration of the microbiome and increasing the risk of obesity and muscle gain. And in our school-age children, we cannot stress enough the importance of activity and importance of sleep hygiene and the importance of reducing screen time. This is always a battle. If you have children, you know that. Also avoiding medication that promote weight gain, and also avoiding the added sugar and the ultra-processed food. But we as individuals can do so much. It has to be also combined with an effort at the public health level. And these can be through promoting awareness and health literacy, what we're doing right now. It can be also providing healthy nutrition and daycare and school system. It can be through reducing the commercial for this ultra-processed food and high sugary beverage. Also like social determinants of health are really important massively because, as we said, food insecurity can be a risk factor for this weight disorder. And also be aware about this environmental exposure. These forever chemical, they do disrupt the endocrine system and they increase the risk of muscle. And there is actually data coming, including some environmental pollution like chloride being associated with high risk of muscle. So this takes us to the next objective, which is evaluating the screening and diagnosis of MASLD. And Dr. Robert has covered most of it. I'm just going to show some visual and kind of stress the message. So how we screen for our patient, we need biomarkers. And an ideal biomarker is an non-invasive biomarker, which means we don't need to do a biopsy or real procedure to get it. Our ideal one is ALT. This is what we have used for decades, and we can still use for the time being. But there are more that are kind of evolving, and I have a picture of them right down there, including the FibroScan, which is an ultrasound-based biomarker, and the MRE, which is an MRI-based biomarker. But the issue with these new technology is the reproducibility needs to be kind of studied, so they're not really well validated in the pediatric age group yet, especially the ultrasound. The MRE has more data, and also we need to use these for monitoring and for monitoring of progression as well as the response to treatment. So these need to be validated in this setting. But we're fortunate that we have some of these additional biomarkers at this stage. And we have the gold standard. The gold standard of the diagnosis of MASLD is a liver biopsy. However, the liver biopsy requires in the pediatric age group sedation, so you cannot do it in a regulation like this young adult is having a liver biopsy. It's costly. There's some variability in the interpretation based on the pathologist who read the biopsy. And at the end of the day, you are sampling 1 of 50,000 of the liver. So you're sampling a small area of the liver and thinking that you're going to have a good assessment of what's going on. But it's not the case always, and I will show you why. So this is, when you do a liver biopsy on a patient, this is what you're going to get. And actually, believe it or not, this is a patient with severe MASH, and this is a patient who was 10 years old at the time of biopsy. He had other genetic predisposition, But again, you cannot assume that this disease is not going to be severe in the pediatric age group. And this is a liver biopsy from a patient. You can see some fat accumulation. This is the white dot, the white kind of space. But you can see some cells are kind of balloon, like this cell. It looks like a balloon hepatocyte. And all these blue infiltrate are immune cells. And this is a way how we can assess severity or give a score to the disease by looking at these components: the inflammation, the ballooning, the amount of fat. But again, fibrosis is the factor that's most associated with progressive liver disease and with morbidity and mortality. So we pay a lot of attention to fibrosis. And the way we assess fibrosis, this is a platform. You see this blue band around the cells. Those are like signs of fibrosis. And you see this big blue band here. This is what we call bridging. This patient is almost developing cirrhosis. Cirrhosis are those cirrhotic nodules. And you have the impression that this patient is developing a nodule right there when he's only 10 years old. So this is, early intervention is really important in this setting. So there are multiple non-invasive biomarkers that are still under evaluation. I'm not going to go into detail, but you might hear about them. Some people might prescribe them. Some are commercially available, including the ELF, the enhanced liver fibrosis test that I have here in bold. But we are more interested in the imaging-based biomarker. Those are the ultrasound and the MRI. And the ultrasound and the MRI, both of them can give you an indicator of the stiffness of the liver, which means how much fibrosis is in the liver, or as well as how much fat is in the liver. And this by the CAP, the control attenuation parameter by ultrasound, or the PDFF, or the proton density fat fraction by MRI. So in pediatrics, there is emerging evidence that support the use of these imaging-based biomarkers, including the FibroScan. And I'm including here like cutoffs for you, like not to memorize or anything, but to understand how we make sense of these numbers, and we stratify the severity of the patient based on the number this FibroScan report give us. For example, if I do a FibroScan on someone and the vibration control transient elastography is 10, this somebody with intermediate stage fibrosis. Most of my patients in the fatty liver disease clinic have an S3 or steatosis more than 280. They have significant fat in the liver. So the other biomarker modality is MRE based or magnetic resonance elastography, and this is the bladder that Dr. Robert was speaking about. You put it on top of the liver, you send this vibration. This vibration is sensed, and it gives you an assessment of the stiffness, and it gives you this color code. You see how it's kind of very different color code, and the hot spot, the red spot, are the area that have the most fibrosis. So if I do a liver biopsy from this spot, for example, I'm going to have a very high fibrosis score, a fibrosis grade. But if I do a liver biopsy from this side, it's going to show as normal. That's why the liver biopsy is not very accurate, and the MRE can give you a more comprehensive assessment of what's going on in the liver. And it's thought to be better than the FibroScan because, here with the FibroScan, the thickness of the abdominal fat can interfere with the signal, and it might not be very accurate for somebody who's significantly obese. But the MRI, this is not much of an issue, so this is an advantage of using the MRI. And it gives you an information about the larger area of the liver compared to the FibroScan. The FibroScan is sending a vibration through a small kind of line, and this is more kind of a plane, makes sense? So that's why if you have access to an MRI, this will be a better option, but it's of course more expensive. And this is kind of a limitation of using it at a population base. Also MRI, you can also generate report, and you can assess severity of fibrosis or steatosis based on these kind of value. And interestingly, this work by my colleague Alina Allen at Mayo Clinic, they have software that they generate a score from the MRI. And this patient before and after bariatric surgery, you see like they lost most of the fat in the liver just after bariatric surgery. For example, here the PDFF was 26.2. This is thought to be grade 3 fatty liver. After the bariatric surgery, 3.6, which is normal liver. So it shows you also how patients respond to intervention. But there is area of improvement of the MRI before it can be widely available. If any of you went through an MRI, it's kind of a lengthy path you go through a tunnel. It's kind of scary a little bit, so it's not very friendly for children, especially younger ones. So there are some opportunity to make it shorter, to make it more affordable, more available, and also there is an opportunity to integrate like a automatic interpretation and software to give you the score, because at the end of the day, the clinician wants to know the risk, and predicting the risk with a number is always more powerful. So this will take us to our last learning objective, which is how to manage those patients, require a multidisciplinary team, and what's in the future for this patient. So again, the most important thing, we cannot stress more the importance of diet and exercise. And as we all know, dietary intervention should include less fat, less carbohydrate, less refined sugar, less ultra-processed, trans fat, and more fibers, more fruit and vegetable. And this is indeed the Mediterranean diet. I don't know how many of you are, but this is basically, this diet has been proven to be effective, and it's really good. Also, physical activity is the most important intervention one can do, and this can be in the form of strength training, or it doesn't have to be training. Strength activity and aerobic activity, and actually the bar is kind of high. Like you should do like at least 60 minutes of vigorous physical activity to be considered meeting these standards. So if you are going to be realistic, not a lot of people do that, but this is what's recommended. This is what we should be telling our patient. And limiting screen time. I cannot stress enough the importance of limiting screen time for growing children. Less than 2 hours, please, everyone. And actually, I want to just stress it a little bit more and add another age-based recommendation, like how you manage physical activity and screen time based on the age. And the younger the patient, the less screen time is allowed. So no electronic babysitter. And then also, the other thing is, like, the younger the patient, the more exercise they should be doing. Like 180 minutes for kids less than 2 years of age, they should be like running around the house. So it's normal if the toddler is destroying everything in the house. That's normal. Don't be alarmed about it, because this is what they're supposed to be doing. And also, as we discussed, this MASLD is a metabolic condition. It's a multi-systemic condition. So you have to be aware about the other organ systems of this patient. Screening for diabetes, screening for hypertension and dyslipidemia. Also screening for other conditions like obstructive sleep apnea, which is a condition where patients pause breathing or gasp while sleeping. So it's really important to screen for those. Polycystic ovarian syndrome in growing girls is another comorbidity that needs to be screened for. So this animation did not work. It's supposed to be better than that, but I think it just kind of gets messed up with the conversion. So when to refer to pediatric gastroenterologist. So if you are a pediatrician in the community, when you need to come and see us. This means when the patient needs to come and see us. This means if after lifestyle intervention implementation, the patient still have increased liver enzymes. If they have at presentation symptoms of advanced liver disease, if they have ascites, splenomegaly, or jaundice, those patients need to be seen by a specialist. If you implement lifestyle modification and they're not improving, so these patients need to have a high level of care, and when they come to us, we decide do they need a liver biopsy or not. And we often do a liver biopsy to exclude other conditions, because as I said, pediatric patients are at risk of other genetic conditions, and we don't want to miss the opportunity to treat them early in life. So, and the biopsy can help us with staging the disease severity, but I just explained to you that it depends where you're taking the biopsy from. And at the end of the day, we have to intensify treatment in addition to weight loss and measure with that exercise. Sometimes we use vitamin E. It's borderline effective. It's not like a cure of the condition, but it can help in a subset of patients with proven MASH. The recommendation is not to use it for more than 1 to 2 years if it's not working. And obesity medication that's gaining more traction now is the GLP-1, as Dr. October outline, and we'll talk more about that. Bariatric surgery is an option for patients with severe obesity and other comorbidities. So how we treat patients with MASLD and obesity? And we know that only less than 10% of the patient can achieve durable and sustainable weight loss with just metformin. So we have to be realistic. I think prevention is more important because once the patient are in this vicious circle of being obese, it's really hard for them to lose the weight and maintain the weight loss. And there might be other factors. There might be other genetic factors that's making them more prone to develop obesity. So trying to reverse steatohepatitis patients, in order to do that, they have to lose around 7% of their weight. To reverse steatosis, they have to lose 5%, but to reverse fibrosis, they have to lose 10%. So this is those are big goals, and sometimes they need obesity pharmacotherapy to achieve that. And because if you treat the metabolic comorbidity and you improve the disease profile. And GLP-1 receptor agonist is thought to be the treatment of choice at this stage, especially in patients who have type 2 diabetes or insulin resistance. And with GLP-1, so it's an incretin. It has multi-organ, multi-system effect. It works on the central nervous system. It reduces the appetite and the drive, the craving, and it improves neurocognition. It works on the stomach and it reduces gastric emptying, so the patient feels full early. And it improves the pancreatic function. It has so many protective effects on the beta cells, and it improves insulin sensitivity at the level of the liver, the muscles, and the adipose tissue. So basically, it also reduces the incidence of cardiovascular disease in these patients. It does have improved endothelial function. So no wonder it's the treatment of choice because it has all these metabolic benefits that fix a lot of issues in these patients with metabolic dysfunction. So studies are emerging and showing that patients on GLP-1, they have less cardiovascular event. They have improvement of their diabetes. They have improvement also of their MASLD. So, we started to use these medication in our pediatric population, and I have a list here of approved therapy by the FDA based on the age group. But the two agents that are now approved in the pediatric population are liraglutide and semaglutide. Those are GLP-1 receptor agonists. Liraglutide is an injection every day, so it's nobody wants that, no child wants that. Semaglutide is an injection once a week at the dose indicated. And we spend quite a bit of time trying to make sure that the patient fulfill the indication criteria, but actually anyone can prescribe this. I know that our internal medicine colleague in the Mayo Clinic are prescribing based on the correct setting. There are clear guidelines to prescribe it based on the patient's BMI and other comorbidities. There are clear contraindications, those mainly the thyroid carcinoma, medullary thyroid carcinoma, or a patient with multiple endocrine neoplasia. It's a medication that's contraindicated in pregnancy, and you should be cautious in patients with pancreatitis or gallbladder disease or thyroid cancer. There are a few things to monitor while you start this patient on GLP-1, including maybe heart rate and suicidal ideation. And the main side effects are GI side effects because they reduce the gastric emptying, so patients tend to have vomiting and nausea and they feel bloated. But you can mitigate these side effects by counseling the patient, starting them on antiemetic medication right away. Be cautious about this dose escalation, observing the symptoms closely, educate them about eating small portion food, and educate them not to skip dose because as any medication, it's effective if you take it. So this is the efficacy of liraglutide. This is a pediatric study. And the patient average weight loss at 1 year was 5%. So it's kind of a decent weight loss. This is the weight loss you need to resolve steatosis. But it's kind of fallen out of favor, the liraglutide, because the other agent, the semaglutide, which is once a week injection, have resulted in 17% weight loss over a year. So it's becoming more effective. Interestingly, the newer generation, where we combine more than one G agonist, for example, this agent called tirzepatide, it combines GLP-1 with GIP, and GIP I haven't done there. I took a long-dependent insulin-tropic polypeptide, weight loss of 20% at 1 year. So this is really powerful. And if you combine 3 Gs, those are incretin, you can use up to 25% at 1 year. So that's why the future is kind of promising, because more and more of these agents are coming on the market, and then if you combine more than one, you have better efficacy. And there's a dose-dependent efficacy. I want to speak a bit about bariatric surgery, because you may see more people getting bariatric surgery. There are clear indication of bariatric surgery. As you see here, the indication are BMI-based and having other comorbidities. And among the comorbidities are the ones that we discussed, that we screen for, like diabetes, hypertension, obstructive sleep apnea. The bariatric surgery is a major lifestyle change. Like it requires a lot of lifestyle adjustment and intervention. And the efficacy of the bariatric surgery, I get it, the newer agent, newer GLP-1 receptor agent and the combination, the G combination, are getting efficacy as close as sleeve gastrectomy, for example. So this is the gastric band that you bend the stomach and you reduce the capacity. This efficacy of the gastric band is around 10% weight loss after 1 year. So it's kind of small out figure. I don't see a lot of patients getting gastric band, but a lot of patients are getting sleeve gastrectomy, where you can reduce the capacity of the stomach by cutting off this part of the stomach. And this will cause a weight, it will provide a weight loss around 28% weight loss after a year, so it's kind of decent. And this long wide gastric bypass is both it's a restrictive, because you're cutting off a large part of the stomach, and it's also not absorptive, because you're bypassing this whole loop, actually this whole loop here of the bowel, so this doesn't get exposed to the nutrition. So, and this, as you see, is the most invasive form of surgery, because there's a lot of cutting and sewing, but it does produce, the most effective, it does produce a weight loss of 31% after 1 year from surgery. But, surgeries carries risk of complication, perforation, wound infection, all these things. And these patients are on a very careful and restricted diet, so they are at risk of macronutrient deficiency. And I have to bring back the same message. Like now, bariatric surgery are called metabolic surgery, because they work mainly by improving the GLP-1 signaling. So it goes back that the end result, even we've seen in patients with bariatric surgery, improvement of the GLP-1 signaling. And we reserve bariatric surgery for patients who are significantly obese, they have severe comorbidity, and they are getting weight loss in rapid fashion. While patients, we prescribe GLP-1 for patients who have obesity, but they're not like morbidly obese, and they don't want to go through the significant lifestyle change that bariatric surgery implies. And I'm putting here like the GLP-1 receptor agonist versus bariatric surgery. If you ever think about that, or some of your colleagues ask you like how you make a decision, what should I do, one versus the other. And some of each one of those approach have its own pros and cons. But basically, efficacy is getting close with the newer agent, and also there are like all alternative on the horizon. So there might even be more role for GLP-1 and less role for bariatric surgery. And there are increasing data showing that these GLP-1 are safe. First, we were concerned about cancer risk, but actually meta-analysis have shown that the cancer risk is really not that significant in these patient population. And then at the end, I have to say that the management of this patient population is really a multidisciplinary team approach, where the patients in the heart of this approach, and the lifestyle intervention is the mainstay basically. But also, please screen for comorbidity. Remember that bariatric surgery and pharmacotherapy are options. And I think I'm over time, or I'm gonna just put there's, in the future, there's gonna be more agent for those patients. And Dr. Robert already spoke about resmetirom that's approved in adult, it's not approved yet in pediatric. And we have kind of a wish list for what we want for our patients to be treated with. An agent that's kind of metabolically beneficial, that reduce inflammation, reduce fibrosis. So this is a work in progress. Resmetirom was approved, and it did have some of these benefits. And then we have other agents, the GLP-1 receptor agonists that are used for obesity, now are in clinical trial for MASH with good efficacy, including, for example, tirzepatide and this agent, retatrutide, which is a triple agonist. And at the end, the summary of MASLD pharmacotherapy. So we have many phase 2B and 3 clinical trial ongoing for MASH in adults. We're going to have a challenge extrapolating to pediatric patients because we believe that our disease is a little bit more severe, starts early in life, and is more heterogeneous. And this is the summary of my whole talk. Basically, MASLD prevalence has surged in children and worldwide and carries long-term morbidities. Individual level, lifestyle risk factor, and broader environmental exposure, and social factor are all implicated. And then prevention efforts in primary care and at the public health level are mandatory to reduce the burden of MASLD. And multidisciplinary care model of children with MASLD is essential to reduce the long-term morbidity and mortality. We have novel and effective therapy that are coming in the market, but remember, lifestyle intervention remains the cornerstone of management. And with that, I end.
So early in life, how many of them actually require transplant? That's the big out there. And how many of them develop liver cancer related to the thyroid disease? What's the median age?
Yeah.
Because I feel like committed if they have to get transplant for lifelong liver suppression.
Yeah.
At such an early age. Prevention is very important. That's what we're working here. And I would hate to see kids getting liver transplanted so early in life.
Yeah. Yeah. Yes. Yeah, so the question is regarding the incidence of liver cancer in patients who develop MASLD early in life and the importance of prevention and liver transplantation, yes. So basically, this is one of the unmet need or like the area that is understudied, the natural history of now MASLD, starting in the pediatric population. There are few manuscripts about that. So this is an area that we don't have a lot of information. There are some studies coming up showing that you have maternal obesity, you are at high risk of developing severe fibrosis and cardiovascular outcome that mobility and as well as cancer. But this is definitely increased. Number-wise, I don't think we have enough data to show, to say how many, but definitely it's significantly more increased to the general population. And the patient who would require liver transplantation from MASLD in the pediatric population, we have few of those. Most of the time they do have like a hypothalamic obesity or they do have other compounding risk, but MASLD plays an important role. So we know some of our young adults are getting transplanted, but so this condition can potentially progress really fast. I think the exact number are not clear to say like how many of those, because maybe we don't have a good registry to catch them. So this is an area that unmet need basically, yeah.
Thanks for the summary. It's an excellent talk. One quick question I want to ask you, especially those kids who are growing, let's say, late in Africa. And I was trying to picture what would be the best way of diagnosing those kids at risk of developing MASLD. And I don't know even if they are risk of developing the issue. I don't know, what else we can do for them, particularly treatment.
Yeah, yeah. So, diagnosing them, I think screening with ultrasound at the population basis is not going to be feasible. We still do the ALT level, patient 9 to 11-year-old age, so this should apply there. The best way is prevention. Just starting even before the age of 9, like early in life, trying to implement these healthy behavior and healthy behavior intervention to prevent this. And the thing that worries me is there are also some environmental exposure factor that's kind of compounding that are not yet, and it seemed what Dr. Volger have discussed about how people heat their house and how this have contributed to solar carcinoma. It might, other factors seen in this part of the world. If you look at the map, it's kind of concerning. Why people in this region would say are having this very high prevalence. So there's more that we don't know and more that need to be controlled. But at least at the individual level, implementing these changes early in life do go a long way. Yeah.
Okay, can we say that multivitamins can be related to the MSLD? Because I see most of the people, they give their children multivitamin supplements throughout, even before testing. Since we know most of the medications they're being washed in the liver or the kidney, can it have an effect?
So basically, multivitamin per se would not be harmful. Actually, like there is vitamin D deficiency is very common in patients with MASLD. So supplementing with multivitamin should not be a problem. Vitamin E has been shown to reduce, it's an antioxidant, has been shown to improve MASLD. The problem is when kids take supplements that you don't know the compound. Some of those may be herbal supplements that might be hepatotoxic. So this is the problem. I always tell my patient, you need to know exactly what's in this pill that you're taking, because you might think that you're taking, for example, a good health promoting medication, but it might have some herbal supplement that might have hepatotoxic effect. But regular multivitamins should not be a problem.
Thank you so much, Dr. Have more time for conversation. While we transition, let's do, the lunch slump is kind of setting in, I can see. Let's do like maybe a 2-minute stretch break while Dr. Roberts
Now, I got separation. And like, I would fall asleep fast.
Sarah just fell asleep a minute ago.
here in the States, and then I just
Some like, that's the walk, and that's all of coffee.
and then because of my other friends, so what they told me is still there. All the services, doing it.
And he was like, I mean, sometimes if I would have a bottle of water in the car, otherwise I would just go straight to 7 hours. I would not be able to take an hour. No, I've always thought that.
I will see you if you get a chance. The only chance you can get is just to have, some kind of I went back to Somalia. My intention was just to stabilize this connection, help the family, then look at other options that I can go for, this program abroad. Fortunately, I was and he said, oh yeah, that's a really good place to go as well. So I came here in 2017. And then for the first 2 years, I was just like exploring the environment, getting the stabilization and then in 2020, I started doing the exams. And now, after 4 years, I finished the exams. I recently started working and
If you want to bring it in, the chair.
Hello? And now a lot of people will say,
Multifactorial, right? It's been going on for a long time, but then it's compounded by lack of sleep and all that.
I really should, I'm sure that my PCP would say the top factors that my insurance covered. That will be my 2025 goal, getting an answer. And then
We're coming up to
figuring
New Year's,
out
it's
how
time
you
to,
can
yeah.
drive for more than 45 minutes without getting to
There's something in that kind of went out. It's easy to go on, like you, but I was sitting in the shore, and I was joking around, like runway modeling. So as the plane goes down the runway, I would always fall asleep. But then when it would level out, I'd be like, it was nothing other than just, I think, fatigue and the stress. But the motion, I think, more than anything.
Right, I hate to cut these beautiful conversations short, but we are very close to time, and I want to make sure we give Dr. Roberts the time to really tell us about the most important things we need to know about viral hepatitis, and then to give time for question and answer as well. So I'd like to bring Dr. Roberts back up for 20 minutes about viral hepatitis and community health.
Hi everyone, welcome back, and thanks for staying for the duration. So we'll talk about viral hepatitis, and I'll try to briefly summarize some of the disparities in viral hepatitis that we see among specific racial and ethnic groups globally. I'll talk about viral hepatitis and talk briefly about the hepatitis serologies, because sometimes it's confusing, particularly with hepatitis B. And then we'll talk a little bit about early cancer detection. And when I talk about the disparities, what I'll try to do is tell you about some of the work that we've done here in Minnesota, actually, talking to communities and learning about their perspectives on viral hepatitis. So, in thinking about the infrastructure of health disparities broadly, I'll be quick about this, and I think Dr. Fonkua mentioned several of these issues. So low socioeconomic status is a major contributor to inequity. And access to care is often related to socioeconomic status, insurance, and social geography. And there are cultural factors. So we'll talk more about these factors, but just to summarize, a person's conception of prevention requires a life with margin. So if a person is living a life that is stressed, that has little room for reflection, if they're always busy trying to make a living and trying to earn enough to just survive, prevention is often the farthest thing from their mind. Asymptomatic illness is difficult to appreciate, and I think that's true for all humans. That if we feel well, it's difficult for us to conceive that we might be ill or might be at risk of a severe illness. And that also then relates to the idea of proactive versus reactive engagement with the health system. And the idea of healthcare seeking, when I'm well, do I want to go find my doctor? Versus I wait till I'm feeling really ill before I go to see the doctor. And then there's the issue of invasive tests, and it's funny that came up. And it's a funny thing and interesting what people consider invasive, and it's really important to think about this. That there are many dimensions of the word invasive. For someone, disrobing in a particular setting is very invasive. For another person, it may be receiving a biopsy of their liver. And so it's important that we put ourselves in other people's shoes and feet when we think about what we're doing with testing. Lack of trust can impair healthcare seeking, and it's really important to engage with communities and community leaders. Cultural norms may induce or exacerbate illness. And I'll give you a small story about aflatoxin exposure. So one of my friends is a pharmacologist, toxicologist in Ghana. And there's a drink that's made from millet that is sold, as a, they use it, if you go to a social function, then you'll probably be offered this drink. It's made from the millet that's milled and cooked, and they add spices and different herbs, and it's one of the popular drinks in Ghana. So she went around different markets and got samples and tested them for aflatoxin, because millet, if it's left and not when it's harvested, if it's not dried completely before it's stored, can grow the fungus that releases aflatoxin that is damaging to your liver. So she went, got these samples, tested them for aflatoxin, found high levels of aflatoxin in some of the samples, and published a paper. About a year and a half later, a journalist found her paper, and he put it on the front page of his daily magazine, his newspaper. And so she goes to work, one day about a little bit of a year ago, and the secretary says, there's a group of women from the market who are looking for you. And she thinks, why are women from the market looking for me? But she goes to them and says, Professor Pierpont, how can I help you? And they say, why are you trying to ruin our business? We all make this drink. And we found in the newspaper that you say it causes liver cancer. And she said, well, I'm not trying to ruin your business. My question really was, why is there so much of this toxin in these drinks? And she explained, where the toxin comes from, and said, why do you think that the toxin might be concentrated in some of the drinks? So the woman then explained that when the millet is harvested and dried and prepared for the market, the millet that looks nice and clean and good gets sold as millet. What looks like it might be moldy, well, they buy that because it's less expensive, they mill it, and they cook it, and they prepare the drink. And in their minds, cooking sterilizes the fungus or whatever else it is. They don't realize that aflatoxin is very heat stable. And so then one of the women says, when she explains that, that may be where the toxin comes, one of the women says, oh really? That's what I'm using to wean my baby. baby potentially is receiving high levels of aflatoxin close, from early childhood. So cultural norms may induce or exacerbate illness. And then relative risk is difficult for all of us to appreciate. So you get the medical risks of life are difficult, and I think that also factors in how we in our communities appreciate risk. And then of course we know this, that a previous history or experience of discriminatory practices may discourage participation in research studies, and there's a long history of this, and much of the regulations around research come from past history of this. Okay, so research then can have an impact. It can either contribute to, or it can negate or help address disparities. And genetic differences may not in themselves cause disparities, but a lack of appreciation of the functional relevance of a difference can. And I give the example of 5-FU metabolism because that's one of the studies we did. One of our colleagues, Dr. Diazio, studies the metabolism of 5-FU, which is a commonly used drug for cancer, such as colorectal cancer, for example. And what we did was, in one of our studies where we collected DNA samples from individuals of Somali and Kenyan, we had some Somalis and Kenyans in the study, he looked to see if there were variants he could find in the genes that metabolize 5-FU, with the idea that if you have a gene that causes a protein that is a rapid metabolizer of 5-FU, when you take that drug, you may get very little because it gets metabolized very quickly and excreted from your body. So you may actually get very little effect from the drug. On the other hand, if you become a slow metabolizer, you may accumulate the drug in your body, you may get lots of toxic side effects. And so the interesting thing was that in approximately, I think 200 or so individuals that he tested, he found, I think, 8 or 9 variants that had never been seen in any of the populations that had been tested globally. And so, of course, the question for him was, okay, can he now then actually express those variants and see if they make a difference to how 5-FU is metabolized? So again, genetic differences may not themselves, it may turn out that those variants have no influence, or they may have impact. And it's important that we do these studies. And then a lack of trust can impair participation in research studies. Sometimes people ask me, when I ask them not to participate in the study, are you asking me to become a guinea pig? It's like, am I going to be disadvantaged? The other side of the coin, of course, is that if we have a community where nobody takes part in research, then that community is definitely disadvantaged, because the research is done and a drug is licensed. We have no idea whether that community is going to respond or not respond to the drug. So it's important that communities understand this and are interested in engaging. And Dr. Fonkwa mentioned, for example, that when communities understand this, it's often the case that contrary to what we might think, they might actually be very enthusiastic about participating in research. And then there's the other factor that low socioeconomic status and other social factors may lead to geographic exclusion from academic medical center sites for clinical trials. And sometimes this is actually paradoxical. So, for a long time, some of the major medical centers in the United States were in neighborhoods where the rest of the neighborhood around them was not that developed. And it was interesting when researchers studied this, that they found that even though people in those neighborhoods were right next to a major national academic center, if they needed care, they would travel a longer distance to go to a county or a community hospital, rather than to the state-of-the-art hospital that was right next to where they lived. And so there may be interesting factors that lead to exclusion of people from centers. And of course, we in the healthcare profession at risk of often using complex jargon that inhibits the understanding willingness to participate by people that we talk to, patients and participants. And then, of course, the other issue of access is that health professionals in low resource settings they have limited time or resources to engage in research. And so there's an active effort, for example, to develop community cancer centers, for example, or cancer trials in communities, so that these trials can reach into rural areas, for example, where otherwise it's a long distance to go to a cancer center to participate in the study. So the importance of including all communities in research is highlighted here. So several years ago, I participated in a project that's called the Cancer Genome Atlas Project. So once the human genome was sequenced, and the cost of sequencing genomes began to drop, the National Cancer Institute began this large project, and they spent, I think, over $150 million in this project. What they did was they identified 23 of the commonest cancers and 23, in quotes, rare cancers, about 10 rare cancers. Overall, they had about 33 different cancers. And they did sequencing of tumors that had been removed from patients from all of these different cancer types to try to better understand the biology of these cancers. And our team ended up participating in the projects for liver and bowel cancer. But when they were done with sequencing the individual cancers, by that time, the cost of sequencing a whole genome had dropped to the point where they felt they could at least try to sequence whole genomes for many of these cancers. So they ended up with sequencing about 2,600 whole genomes of these 38 tumor types in what they call the pan-cancer analysis of whole genomes, so consortium. The interesting thing that you see is this, in the sort of teal is the countries where the patients were from who had their genome sequenced. And you can see that there was almost no representation from South America, from Africa, or from parts of Asia. And so this is part of the challenge, I think, of science, is that it's really important that as we do research, we include all communities, because as I mentioned, there's the risk then that some communities are underrepresented. Dr. Lionel showed this. I'm going to switch now more to the viral hepatitis. Dr. Lionel showed this already, the idea of the high prevalence of chronic viral hepatitis B and C that we found in Minnesota Somalis. Rashid found this initially in the hospital-based cohort at Mayo Clinic, and then subsequently, Isa and Nasra demonstrated this in approximately 800 individuals that were recruited from the community here in Minnesota, individuals of Somali background. And we found, as Lionel showed, that we had fairly high rates of hepatitis B. I just want to point out that hepatitis B rates start to go up relatively early in life. So by the 21 to 30 year age range, there were quite a few people already that had been tested that were positive. Overall, it's about a 12% rate. But hepatitis C tended to be seen in people later on in life, and you can see in adults. The overall rate about 5 to 6%. This is important because, of course, hepatitis B, because it starts early on in life, and I think Lionel mentioned this, tends to cause liver cancer earlier in life as well. And so in Sub-Saharan Africa, we begin to see cases of liver cancer starting as early as 20 years of age and beyond. And of course, hepatitis C tends to cause cancer more in people's 50s and 60s. So African immigrant communities can reflect the socioeconomic and the cultural dynamics of their home countries, and so the home communities. And so here are a few items that I made as a synopsis from the paper that, if we have time, I might talk through I might show you some of the quotes. I'm not sure about our time, so I thought I'd just summarize the key findings. So there is social stigma associated with viral hepatitis. And that causes a sense of secrecy. There's a high value of community acceptance in African communities. So people want to be accepted, to feel like they're part of the community and that they are accepted by everyone. So they're very unlikely to share the fact that they have viral hepatitis. And then there's often a suspicion of Western medical systems and suspicion of the idea of beneficence in healthcare. So in healthcare, people, one of the ethics of healthcare is the idea of beneficence, of doing good, of the care that we provide creating a benefit for people. But there's often in communities a suspicion of this. There are often preferences for spiritual, traditional, or alternative medicines. And sometimes the preferences relate to cost. I was just talking this week to someone that's fairly highly educated. He was diagnosed with liver cancer just, and I think about a week and a half ago. He went to see a cancer center in the capital in Ghana, and he was quoted several $1,000s a treatment for a treatment that he'd have to take for several months. And then he said, well, I thought, I'm not sure I can afford this. So I came back home. I went to the city that's closest to me. I found someone that had a herbal business that was selling different herbs, and they offered me a treatment that cost much less. And so, as of the time I spoke to him, that's the treatment he was on. And so, costs factored very much into his choice there. Then there's aversion to invasive procedures and surgery. We talked about that already. And that, for example, was interesting when we studied hepatitis C treatment. For a long time, in order to be eligible for hepatitis C treatment, you had to have proof that you had scar tissue in your liver. And the commonest way we used to create that proof was by doing liver biopsies. And we were seeing that people in the immigrant African communities were not being treated or cured for liver cancer, for hepatitis C at the same rate that people in the non-immigrant communities. And when we delved into it, we found the reason was not that people were not told there was a treatment for hepatitis C. It was not that they were not offered treatment for hepatitis C. It was not that when you did treat them, the ones who were interested and were eligible for treatment, when you did treat them, that they didn't have a different rate of cure. That the likelihood was that, what it turned out was that they were more likely to decline a liver biopsy. Okay. So when things changed and the requirement for liver biopsy was no longer present and we could treat everyone who's diagnosed with hepatitis C, the disparity disappeared, because now it was fine from the perspective to take the pills for treatment of hepatitis C. So that also is an issue. And then there's a sense of stoicism or fatalism also in many cultures. The idea that our lives are predestined, and if something's going to happen to us, it will. And so that to some degree it seems as though we have less agency in determining things that happen in our lives. And then finally, there's this idea of resilience. And the resiliency here, I think, is tied for immigrant communities often with the need to be providers for people either in their local community or in the community that they left back at home. So if the focus is on, boy, I need to work 2 or 3 or 4 jobs so that my cousin that's back home in Africa can go to school, there's much less focus on, I'm not feeling quite well or have a little pain here, because those things are that much more important. So this is a distillation of more that we could talk about, but I think in the interest of time, I'll summarize this here. And then some talk about barriers, lack of insurance. People are considered that the legal immigrant status will be jeopardized if they seek care, limited health awareness, language and cultural barriers, and I talked about this. There's focus on those left behind, so lack of attention to personal health. Okay, so what are the things that we can do? And one of the questions that we asked was, where would you like to receive information? And people in African immigrant communities are open to information. They identify trusted community leaders. So community engagement is key. And it's important that we include both participants and clinicians and researchers in the engagement with communities. It's really key to develop and demonstrate compassion and genuine concern, because this takes effort and it takes time. It takes a time to actually be in communities, to be able to interact with the communities and develop a sense of comfort within the community with our presence in the community. The return of research results is key to community participation. And this, of course, is for everyone, not just people in particular communities. And so this is something that is important for us to think of as a priority. It's often the case as researchers that we think, well, I did the research, I published it. But unless we have a mechanism for getting that information back to the community may never read our paper. And so these are important to be able to communicate back. You know, this is what we learned, reflect it back to the community. But it's important to recognize that community leaders and institutions can be trusted partners. They can help us address community awareness, and that reduces stigma and reduces the silence. And communities can really help us advocate for structural change in medical and civic institutions. Okay, so what are some strategies that we can do to address, and then I say hepatitis B here, but really all viral hepatitis disparities. Normalizing illness is important. It's important to recognize, for people to recognize that these illnesses, viral hepatitis, is actually quite common. And it's often in no fault of people that they have it. Most people in Sub-Saharan Africa who have hepatitis B acquired it either at birth or before the age of about 5. They had no influence on it. It was nothing that they did. So it's important to normalize it, reduce the stigma. It's important to improve access to health care, health insurance, and address the fear sometimes people have of whether it's deportation or because that then affects their likelihood to access health care. As we talk about health information and awareness through trusted community leaders, addressing the suspicion of the healthcare system, and increasing the diversity of the healthcare workforce can really help this. And if we can't, we can recruit culturally congruent patient navigators to help our patients to feel more comfortable in the healthcare setting. Developing culturally appropriate engagement in clinical care and research studies, and helping people to be aware of the positive outcomes from science-based medicine. I say that, I don't know if he's still working, but one of the masjids, one of the leaders in the masjid in Rochester had viral hepatitis, developed liver cancer, had a liver transplant, and was living many years after his transplant. That person had more of an impact on healthcare and acceptance of this path as treatment than anything that you or I might say, because the community could see the impact of his treatment on his health. So increasing awareness of positive outcomes can be helpful, and then developing and using non-invasive screening and treatment strategies. So if, for example, we can reduce screening to a blood test rather than an ultrasound, and anything we can do to simplify care can potentially be quite helpful for communities where the invasiveness is an issue. And we talked about the fact that invasiveness comes in different forms. And this is just to make the point that there's great variability. There's a high incidence of liver cancer deaths in Africa and in Asia, and you can see both Africa and Asia have the darkest colors. But I think if you look at the United States, it's not, light green. So the United States is an intermediate incidence country for liver cancer. Liver cancer rates have been increasing. The reasons we talked about hepatitis C, non-alcoholic fatty liver disease over the years. And if we broke it down by states, you will see that there are states in the United States that if they were a country, they would be a high incidence country for liver cancer. You know, think places like Texas and Louisiana. And so there's a number of states that have high incidence of liver cancer. And I actually had some slides and that broke it down also the incidence by race and by county. And that's really instructive for us here in Minnesota, because actually when you look by race and by country, you find that in people of African descent in Minnesota, we have clusters in Rochester and in Minneapolis and in St. Cloud, and actually there's a cluster, I think must be around Duluth in northern Minnesota, that have high rates of liver cancer. The same is true also for individuals of Asian ancestry and for people who are Native Americans. And so even within Minnesota, there's variability, and we can see it in major population centers. I'm going to, I think, make the point about vaccination. We mentioned this before. Vaccination is important, and you can see that in many places in sub-Saharan Africa, there is no universal birth dose. The sort of orange in places where there's no birth dose vaccine for hepatitis B being given. So the majority of the countries in sub-Saharan Africa. Now the Global Alliance for Vaccines is just in the process now of starting support for the birth dose in Africa. They are currently, I think, reviewing applications for countries that are going to get support next year. But it took advocacy over about a 15-year period to get them to agree to support the birth dose of hepatitis B vaccination in Africa. And so consequently, Africa lags behind in hepatitis B diagnosis and treatment. So, so here, the teal is a percentage of hepatitis B infected persons diagnosed to the end of 2019, and then the orange yellow is a percentage of people treated to the end of 2019. Globally, only 10% of hepatitis B infected persons know, or at least in 2019, knew they had it, and only 2% were treated. In some regions, you know, in the parts of the Western Pacific, for example, you know, it's 18% of people knew they had it. In Americas, 18% of people knew they had it. But again, treatment was in the range of, you know, 2 to 5%. Look at sub-Saharan Africa, only 2% of people infected know that they have hepatitis B, and less than 0.1% are in treatment. So huge disparities there, and as we see colleagues then or communities that are immigrating from Africa, that's the pattern that they're bringing with them. And so it's important that we are aware of this. I'm going to skip this. I think Dr. Lionel talked about the early age of onset of liver cancer. These are just studies that we did that show that. This is an important one because it carries the idea that this is people who are diagnosed with liver cancer in the United States. And this is looking at the age at which they were diagnosed with liver cancer, and the age tracks with where they were born, or from a country from which they immigrated to the United States. And you can see here that individuals who came from, for example, West Africa, more than 50% of them were under the age of 50 at the time of their diagnosis with liver cancer. And so the people in the United States being diagnosed with liver cancer, but their age at diagnosis tracks with where they were born. And I'm going to skip this. This is just a community-based survey talking about people's familiarity with viral hepatitis or liver cancer as a disease, the symptoms that a person might have, how people acquire viral hepatitis. There's names for viral hepatitis in different communities, how you might prevent viral hepatitis, how they might access healthcare, you know, the barrier that legal status and health insurance places, the whole issue of stigma, suspicion of the medical system, health education needs, the idea of that they were interested in partnerships for health education, role of their community and spiritual leaders, community resources that they look for, and the idea of community dissemination, and that they were very interested in learning more. And again, talking about awareness of how liver disease progresses, for example. So that was a quick walkthrough. I think I mentioned this. Should we stop now? Okay. We'll stop now. Thank you.
So we have maybe time for 2 questions and time for conversation afterwards.
Okay.
Time for 2 questions. We have one here and
Thank you, Roberts, for this very interesting and thought-provoking talk. I am quite interested in the serotypes of Hep B or Hep C and D that are common among the African community here. And interestingly, do you see any fulminant hepatitis among your patient cohorts? Thank you.
So that's a great question. Is the interaction between the Hep C genotypes and the expression of the disease. So I think one of the things to recognize is the fact that there's this very strong association between the virus in its genotype and who is the person that's infected in terms of the expression of the disease. The clearest example is in South America, where there are places in South America, Mexico, for example. There are places in Mexico, for example, where there are communities that if they get the genotype of hepatitis B that is prevalent in that community, they express no illness. So it's like they and the virus that they have are completely adapted. But if someone who is of Caucasian race gets that same viral genotype, they frequently will get fulminant viral hepatitis that's lethal. So it just gives you an idea of the association. In Alaska, there's a range of genotypes of hepatitis B. The genotype F, for example, is associated with early onset of liver cancer around the age of 20. But genotype D, patients almost never get liver cancer. So very interesting changes. And so when we go to sub-Saharan Africa, for example, in the western part, we have genotypes A1 and E. We have that early age of onset. We are not sure whether it's only the genotypes or whether it's some of the other associated risk factors like aflatoxin. And when we go to East Africa, we see a lot of genotype A1. And again, there we see a fair amount of liver cancer there as well. But in some of the communities, it's at older ages than other communities.
can we give it to Amna and then we'll come to you guys?
Thank you so much. So you had a slide with showing the gender differences in HPV. And so I had a question about why we saw more incidents of hepatitis B in women versus men.
Difficult to know for sure what accounts for those differences, and those are part of the reason we wanted to do the community study. But I think even in the community study, we saw some differences, and so it's interesting. In some places, and I think traditionally in many communities, we tended to see hepatitis B at higher rates in men than in women. And some of the thinking was that it might have been related, for example, to the fact that men might have more high-risk behaviors. Some of the ways that men acquire hepatitis B in certain communities are related to, for example, scarifications, or in some places circumcision, where circumcision is done with the same instrument So then there's a question of whether in some of those communities, if for example it's male circumcision predominant, then you might see viral hepatitis more prevalent among male individuals. So and then of course for women, there's also then things related to childbirth, where they might have more exposures to healthcare facilities and might be perhaps more at risk of acquiring infections in the healthcare setting, where if there's not as good attention to infection prevention practices. So I think that there's a lot of things that could be factors within those observations that we don't know for sure.
Thank you very much, Louis, for the excellent presentation. One thing that touched me was the story you said about the gentleman in Ghana, where cost was this way factor for him to get maybe the best treatment. And similarly, Louis, what I have seen in Somalia is that also the other slide is showing about the research information that was coming from Africa as part of the Harvard's program that was virtually zero. One thing I've realized was that the cost of chemical reagents is equally high in Africa. So sometimes I think if we need to make a change, either in treatment or even in research, we have to maybe negotiate with either the pharmaceutical companies as well as biotech companies to bring the cost down. And sometimes, and this is what I've seen for chemical reagents, is that I don't want to mention names of biotech companies, but they deliberately deny access for more information about the cost of the chemicals if they see that you're accessing from a place like Somalia. And when you come here, you can clearly see at the difference, goodness me, you're talking about maybe more than 50%. Even when I try to see if we can buy from here, they won't allow you. So I think, Louis, what we need to bear in mind in the future is that we have tasks in our hands, whether it comes for treatment or chemical reagents. Otherwise, I think we'll have this issue in Africa for a long while. Thank you.
I think maybe we'll stop on that note, because that's an important comment.
Thank you, Dr. Roberts, Dr. Fankoa, and Dr. Ibrahim for today's talk. Before we close, we want to share with you the Somali Health Advisory Committee's website. As you probably are learning, SHAC is a community volunteer group. We're a group that have gathered because we are concerned about the health needs of African immigrants, Asian immigrants in Minnesota. We called it the Somali Advisory Committee, but really we focus on the needs of a lot of our immigrant and refugee communities. Viral hepatitis and liver cancer is part of the work we do, but we look at other diseases and illnesses and conditions that impact more Americans. So on our website are many resources, health education, research publication, some of the work that we talked about here today. There's also a way that you can become involved if you're interested in participating, joining some of our efforts, or just staying in the know of what's going on, what things are coming up. Feel free to register. I want to show you, we have a couple of videos that we developed as a resource for the community, for primary care providers and for other healthcare providers. Jessica, if you can play the animation. Actually, let's do this first video. They're very short. One is 4 minutes, one is 3 minutes long. So you can start there. So this first video is about clinical trials. It's all in Somali. It was developed by Dr. Fankoa and other colleagues from SHAC. And it's Somali, encouraging people to participate in clinical trial. Many of you know Firdousa, who's a Somali actress, environmentalist, who's in this video. The second video, I'd like to play the whole thing. Wait, Jessica. So Jessica is the animator of this video. We have a Somali journalist that is doing the voiceover, and it provides basic education about hepatitis B with English subtitles. So we'll watch this one together.
Okay, toban ayaa qaba cagaarshowga nooca B oo jirka ku reega chronic. Cagaarshowga nooca B waa virus keeni kara caabuq infection beerka ku dhaca oo halis ah. hooyada qabta cagaarshowga B waxa ay u gudbin kartaa ilmaheeda xilliga dhalmada. Cagaarshowga hepatitis B waxa kale oo lagu gudbin karaa dhiigga, dhacaanka jirka, galmada, ama in la isla isticmaalo cirbadaha. Cagaarshowga B sida badan marka hore calaamado ma leh. Marka ay calaamadaha cudurku soo baxaan waxaa ka mid ah in ruuxu isku arko daal, cunto xumo, lalabo, matag, kala goosyada xubnaha oo xanuuna, qandho, calool xanuun, kaadi madow iyo maqaarka oo midabka jaalaha ah yeesha. Cagaarshowga B aan la daweyn wuxuu keeni karaa cudurro halis ah oo beerka ku dhaca sida beerka oo dhagaxooba oo loo yaqaano cirrhosis ama kansarka beerka. Calaamada lagu karto beerka inuu dhaawac gaaray waxaa ka mid ah calool bararka, dhiig, lama tago ama jaawareer. Ilmaha marka ay dhashaan waa in la siiyaa tallaalka cagaarshowga B 24 saac ee ugu horreeya noloshooda. kadibna waa in loo qabanayaa qaybaha kale ee tallaalka hepatitis B 7-aad, 6-aad, 7-aad iyo 7-aad. Tallaalka waxa uu ka difaacayaa inuu ku dhaco cagaarshowga B. Sida keliya ee lagu ogaan karo inaad cagaarshow qabto waa inaad la hadasho dhakhtarkaaga si lagaaga baaro. Cagaarshowga nooca B waa cudur aan jirka bini'aadamka ka tegin abid. Haddii uu ku hayo cudurkan waxaad yarayn kartaa waxyaabaha caafimaadkaaga lidka ku ah. Waxaad kaloo qaadi kartaa tallaabooyinkan. 1. raadso dhakhtar aad ku kalsoon tahay si uu ula socdo caafimaadkaaga guud. 2. 6 biloodba mar baaritaan ultrasound ah hala sameeyo. Ultrasound wuxuu sawir ka qaadaa beerka si uu u muujiyo isbeddel kasta oo uu keeno fayrasku. 3. in 6 biloodba mar la sameeyo baaritaan shaybaareed si loo eego calaamadaha iyo isbeddelada uu keeno fayrasku oo ay ku jiraan in uu beerka kansar ku dhacay iyo in kale. 4. dhakhtar aqoon u leh cagaarshowga B wuxuu kuu sheegi karaa markaad daawo u baahan tahay. daawadu waxay kaa caawinaysaa inay yarayso dhaawaca beerka soo gaari kara. waxay kaloo ka hortagtaa kansarka beerka. caafimaadku waa muhiim. haddii aad qabto wax su'aalaha oo ku saabsan cudurrada beerka ku dhaca fadlan la xiriir dhakhtarkaaga.
So again, this video is available to everyone to use with their patients as part of different programs you're doing, and there are a couple of other resources that are on this website. I want to give Dr. Fungo 1 minute to give to share about the Africa Provider Network, and then we will wrap up for today.
Thank you, Nasra. I'll be brief. I think the theme today has been prevention is better than cure. And I think for a lot of the liver diseases we talked about, really we can intervene very early, from vaccination to screening to early detection to linking patients to the appropriate care. And as we're having meetings about this, something that came up was, you know, why don't we create a coalition of providers caring for patients with liver disease in the state of Minnesota? And from primary care providers to specialists to students, public health specialists working around this this topic, to have a united front for community engagement initiatives, education initiatives, research initiatives, and we've created a coalition. So far, I don't think we have a real name yet or an acronym yet, but it's the Minnesota Provider Liver Coalition. And we welcome everybody. We've had a number of meetings so far. The 2 themes that emerged were education, and these are themes from the community providers. So really the agenda is not predefined. It's coming from the community providers. This is one example of what they wanted, education about viral hepatitis and liver cancer. And we hope to continue to add to that agenda. The other thing that came up was kind of building a registry of these patients that are at risk. in our catchment area here that we can follow for different outreach initiatives, screening. We talked about some of the uptake that's low for patients with liver disease, for liver cancer, 14%. How can we improve on that? Are there non-invasive tests that we can bring into the community? So those are all initiatives that we hope we can accomplish as part of that group. So I think on the SHAC website, you can contact us through that. If you're interested in work in the liver space, whether it be at the primary care level or the research level or specialist level or public health, we welcome everybody, students, everybody. I think you can all contribute. So yeah, thank you.
If you want to claim CME, CEU hours, fill this out. We hope that every single person here will fill out the evaluation because this helps us improve this. We do this annually as part of World Liver Cancer Awareness Month. In the past, we've done it virtually. This is the first year we're doing it in person. So we appreciate you coming out to join us this afternoon and this morning. So fill out the evaluation. We'll follow up with an email that gives you access to the PowerPoint presentation and some of the recordings from today. Yes, make sure you sign in. If you haven't signed in, we need your email address so that we can email you some of these things. And we thank you for spending your day with us. Have a blessed afternoon. Yeah, if we can get a picture in front of the shack, signage out there, please give us like 30 seconds, quick picture. Okay. So there's a shack poster outside, let's all gather around
Yeah.